This is a big portion of what I do, and what I'd like to go through in today's discussion is how I go about it and what I think is a proper medical evaluation. We're going to talk about the causes of impaired decision-making capacity, and that's going to be a highlight. For some of you, this will be a review, but I hope you'll all find some valuable information in it. Next slide, please. Decision-making capacity has really three essential requirements. Somebody has to be able to communicate their choice, and that sounds pretty obvious. If they can't communicate, then they can't indicate what their decision is. So this may play a role in if you're in hospital or intensive care unit settings where people may not be able to communicate. The person has to demonstrate that they understand the relevant information that's being presented to them and that they can rationally weigh the risks, the benefits, and the available options for the decision at hand. And that's the process of assessing their capacity, is that do they understand relevant information and can they rationally weigh risks, benefits, and available options? But the real key here is for the decision at hand. You may know that only a circuit court judge can determine a person to be incapacitated. As a physician, I cannot do it. I give a medical opinion on whether somebody has or does not have decision-making capacity. So it has to be relevant to the decision at hand, and we'll come back to that central point throughout this discussion. Next slide, please. Next slide, Dan. In healthcare settings in particular, it's surprising to realize how common incapacity is. These are studies that were done some years ago, but they indicate that half of hospitalized adults lacked the capacity to consent to medical treatment. Many of these people have signed their consent forms, but when they were really evaluated, they were found that they really didn't know what they were signing and they were not able to make a rational decision about it. Incapacity is often not recognized, that only a fourth of such people are actually recognized by their medical providers as lacking capacity. And these numbers, although a bit dated, are still current today. So it's pretty common in healthcare settings. It's going to be common in other settings as well. Next slide, please. I want to talk about the area that we're dealing with, which is cognitive function, your ability to think clearly. So let's define this. What is cognitive function? It is the seamless sum of a wide variety of individual intellectual abilities, literally dozens of intellectual abilities that blend together in a seamless manner that create who you and I are and how we think and operate every day. Now, on this slide, I've indicated some key intellectual abilities. They're key because these are the problems, the intellectual dysfunctions that occur when older adults develop a dementia process. There's memory, and memory can be grossly broken down into short-term memory and long-term. Short-term memory, what did you have for breakfast this morning? Long-term memory, what's the name of your 5th grade school teacher? Okay, so these are the brain handles these two forms of memory very, very differently. And those of you who've worked with older adults with significant dementia know that long-term memory might still be intact, even though they can't remember what they had for lunch an hour ago. But long-term memory is a different process, but they're both affected commonly. Orientation, who are you? Where are you? What day is today? What time is it? Calculation, the ability to manipulate numbers or add or subtract or make change for $1 in your head. Nope, don't go forward yet, go back, thank you. All of us can do calculation, some of us much better than others, but we all can do it. And we want to assess this in the process of deciding whether somebody has cognitive dysfunction. Language function is a highly complex, highly intellectual process that grossly can be broken down into receptive language function, which is what you're doing now, listening to me talk, and expressive language function, which is what I'm doing now, talking to you. So there's expressive function, you're able to have a thought in your head, find the words for it, and express those words. And receptive function, you can hear those words, you understand what they mean, and you're getting the idea that I'm trying to communicate to you. A very complicated process. And people with cognitive dysfunction may have problems in one or both of these areas. Visual spatial processing is the ability to interpret what your eyes are seeing and your brain is interpreting of the world around you as you walk around the world. It also involves remembering faces, seeing a face and remembering who that person is and their name. It also involves being able to get around town and locate yourself in familiar places. And as I'm saying this, those of you who work with dementia patients realize how common these dysfunctions are in dementia. Now we come to the real crux of today's discussion, which is effects of judgment and reasoning. These are specific intellectual functions that play into overall cognitive functioning, but they are very abstract and they're very difficult to quantify. It's pretty easy for me to quantify whether you are oriented and whether you can spell your name backwards and whether you can make change from $1. But when you're asking somebody about their judgment or trying to assess their judgment and their reasoning, which is what we're doing when we're assessing decision making, it's more challenging. It takes more time, and you have to really sort of nuance the situation. Finally, personality can change as a portion of cognitive dysfunction. Patients with dementia often have changes in their personality, sometimes better, usually worse. Next slide, please. So let me ask you to consider a question. Which one of the following is true? Cognitive dysfunction and dementia are synonymous terms. Dementia and Alzheimer's disease are synonymous terms. Cognitive dysfunction is a form of dementia, or dementia is one of several possible causes of cognitive dysfunction. Take a pick in your mind, which one you'd like to select. Next slide, please. And I want to emphasize in this discussion that dementia is one of several possible causes of cognitive dysfunction, and we'll look at the other causes. But it's unfortunate that in common practice, these terms are flipped around as if they mean the same thing. Cognitive dysfunction does not mean the same thing as dementia. There are many forms of dementia besides Alzheimer's disease, and we'll look at that in this discussion. And cognitive dysfunction is not a form of dementia. It is a general category that has multiple causes. So we want to look at those causes. Next slide, please. What are the 7 common causes of cognitive dysfunction in older adults? So here are the first 3. You can't hear well. The person can't hear well, or they're not listening. And it may sound curious to do that that's a cause of cognitive dysfunction, but it certainly can be confused with cognitive dysfunction. If somebody can't hear, they often will misinterpret, or they literally can't hear what's being said to them. So how are they going to remember and interpret it? If they're not listening, something that's not just limited to seniors, but all of us do this at some time. You tune people out. Somebody you're living with, a spouse or a partner, says something to you. And if you're taking a history from a spouse or a partner or a caregiver, and they say, well, you know, I talk to him and I tell him something, and I say, well, what do you think? And he looks at me and he says, well, what are you talking about? Well, maybe he can't process what she's saying, or maybe he can't hear, or maybe he just ain't listening. He just is tuned out. So keep that in mind. The third possible cause of cognitive dysfunction in an adult is that they have an overbearing spouse or an overbearing caregiver. And you're going to run into this pretty frequently. You'll get clues that this is the case if you're interviewing the person and the spouse and caregiver keep butting in or answering questions for the person. And the person may be very passive and let the other one answer their questions. You sometimes see this in couples who've been together for decades, where there's one who's more dominant and one who's more reserved, and the dominant person really thinks for the two of them. So it's very the reserved person can be misinterpreted as not being able to understand or make their own decisions. And in that case, the client would look to the spouse, the overbearing spouse and caregiver, to answer their questions, because that's the status quo for them. Often you may find a client who appears to be intimidated by the spouse or the caregiver. And for that reason, I will always do my evaluations completely private with nobody else in the room but the client and myself. So we're looking at 7 common causes of cognitive dysfunction. Next slide, please. The fourth is that the person is having impaired cognitive performance because of an adverse drug effect. You would not believe how common this is. As a medical doctor specializing in the care of older adults, I just can't stress this enough. And when I lecture to other physicians, I try to really drive this point home. Adverse drug effects are very common, especially in the older population, but they are not commonly recognized, either by the patient, by the family, or by the medical provider. And the average older adult in the United States today is taking at least 5 prescription drugs. So they're just a drug side effect waiting to happen. Any drug can cause adverse cognitive performance anytime. Even a drug somebody's been taking and tolerating well for years may now start causing them toxicity in the form of impairing their thinking process. And the more drugs a person takes, quite obviously, the more risk they have. So if you're taking 5 or more prescription drugs, there's a lot of drug-drug interaction that's going on here, and they're very high risk. So it is very possible that somebody's cognitive performance or decision-making is impaired because of a drug side effect. And I try to screen carefully for this in my evaluations. Next slide, please. Depression can cause cognitive dysfunction. These symptoms of depression may be intermittent, they may come and go, or they may be persistent. They are very common. At least a fifth of community living seniors are experiencing intermittent or persistent depressive symptoms, and over half of seniors who are living in assisted living or nursing home level settings. Next slide, please. Depression in older adults, actually in depression in an adult of any age, can have 1, 2, or 3 forms of manifestations. But in the older adults, it's more often the cognitive dysfunction. So the first is that depression manifests with depressed mood or affect, which is what most of us are familiar with. And most of us at this seminar today have personally experienced periods of depression or have been with a loved one or a dear friend who has gone through a bad depression. And we've experienced that social withdrawal, loss of interest, just a pervasive sadness. But keep in mind that there can be other symptoms that don't first appear to be depressive symptoms, but actually are, such as excessive anxiety, irritability, negativity, sustained anger, ruminating thoughts where you just have this repeated thought that you can't get out of your mind. These are actually more common in older adults. So it's not necessarily a depressed mood. It can just be irritability or negativity or anger. The neurovegetative signs are psychosomatic. That is a psychic cause of a physical or somatic problem. So there can be changes in sleep or appetite, too much or too little. There can be problems with gait and balance, like stumbling and falling. There can be onset of incontinence or bowel or bladder dysfunction of other forms, which can be physical manifestations of a psychic illness, that is depression. And for this purpose, I want to highlight that cognitive dysfunction can be a manifestation of depression at any age, but it's more common in seniors than in younger adults. And you'll see in a moment when we look at dementia, we have to exclude the possibility of an existing depression. So this again can be a cause of cognitive dysfunction. Next slide, please. Another non-dementia cause of cognitive dysfunction is delirium. Delirium is a medical phrase, a medical syndrome. Simply defined, it's a change in mental status due to an underlying medical condition. It can be an infection, it can be a drug side effect, it can be dehydration, it can be an undiagnosed cancer, anything could be going on. Now, the delirium, the altered mental status due to the delirium, to the medical condition, typically improves as we treat and reverse the underlying medical condition. But in older adults, that total improvement can take months. So for several months after an acute illness or an episode of altered mental status, somebody could have impaired cognitive dysfunction and getting slowly better. And this is true, the more frail is the older adult, the longer it will take. Some older adults literally never recover their prior level of cognitive function. Next slide, please. Delirium is manifested by impaired consciousness. Now that's different than dementia, which we'll talk about in a moment. Dementia is impaired cognition. All of these other syndromes I've been talking about are causes of cognitive dysfunction or impaired cognition. But in delirium, the patient appears sleepy or lethargic or agitated. In fact, the sleepy and lethargic presentation is more common than the agitated presentation. It's just that agitated people come to the attention of healthcare providers more frequently. They also have trouble staying focused. They have inattention. They just can't stay on subject. So delirium is characterized by impaired consciousness as well as impaired cognition. So there's an area of overlap between delirium and dementia. And important to remember, and particularly when I'm speaking to medical audiences, I really stress the fact that older adults with delirium can have persistent delirium, or it fluctuates. It can be, their cognitive performance may be abnormal this evening, normal tomorrow morning, and abnormal tomorrow evening. And some of you are familiar with the phrase sundowning, which I do not recommend we use. I think it's a socially inappropriate word in medical practice. But it really is a manifestation of delirium, where people appear to become agitated or confused in the evening, but pretty normal during the day. And that, in fact, is one of the hallmarks of delirium, is that it can fluctuate. Next slide, please. So we finally come to the 7th of the 7 common causes of cognitive dysfunction, and this is dementia. So I really want to stress to you that dementia is one of several potential causes of cognitive dysfunction, and you cannot make a diagnosis of dementia unless you've excluded the other 6 above. So what you see on this slide are the diagnostic definitions, or the diagnostic criteria for a diagnosis of dementia. The patient has to have acquired deficits in 2 or more intellectual abilities. And you'll remember a few slides ago, I showed you those key intellectual abilities. So for example, it can be memory and orientation. Those are 2 commonly affected. But these have to be acquired deficits. They used to be normal, but now they're not. So that excludes people who have had cognitive dysfunction all their life, or were born with intellectual disability. The second element of dementia is that these 2 or more deficits are always present, always present. So in contrast to delirium, where it can come and go, dementia stays. Now, the people with dementia can have good days and bad days, but they don't have normal days. The third criterion is that because of these deficits that are always present, the patient has some type of functional dependency. Maybe they need help balancing their checkbook or managing their finances, or maybe they're just completely on the far end of the scale and need complete total nursing care. Finally, to say someone has dementia, you have to exclude that it's a delirium, and you have to exclude an active psychiatric process, which includes depression. And I'll tell you that last part is really pretty unknown among many healthcare providers. I've seen patients misdiagnosed with dementia in the face of acute illness, in the face of an active undiagnosed depressive disorder. So it really, you have to be careful when you give a label of dementia to somebody. Next slide, please. The common manifestations of dementia in older adults that are familiar to many of you are impaired memory and impaired visual spatial processing. Again, these are 2 of those key intellectual properties we talked about earlier. Memory, again, can be grossly broken down into short and long term. Registration is what you're doing right now. I'm speaking, you're registering in your mind what I'm saying. In 10 minutes, if I asked you to repeat back something, that would be short-term recall. Next year, if I asked you to repeat it back, that would be long-term recall. And again, visual spatial processing, which we've talked about, presents as a difficulty recognizing familiar objects or familiar faces, or getting lost in familiar places. So these clinical manifestations are common to all forms of dementia. They may not be there. Somebody can have significant dementia and not have impaired memory. That's possible. But these are common. Next slide, please. Further common problems, as we indicated, are problems with language, comprehension, or expressive. And then changes in behavior or changes in personality are also common, particularly as you get to the middle or later stages of a dementia. And relevant to our discussion today are changes in what's called executive function. Now, these are the so-called higher intellectual functions of the brain. And these involve insight, judgment, planning for the future, reasoning, and a phrase that I really find very helpful and useful is situational awareness. You're aware of what's going on around you. So this is what I'm assessing when I'm looking at an older adult and trying to decide if they have decision-making capacity. I'm in this abstract, nebulous area of executive function. And again, it takes time to really tease out whether somebody is intact or is not. And I'm just going to break here and again tell you I encourage your questions. Go ahead and put them in the QA, and I'll certainly be happy to address them at the end of the discussion. Next slide, please. Two key points about dementia in seniors. Number one, dementia is underdiagnosed. Over half of older adults who have dementia have not received a medical diagnosis. Part of this is is ageism. Well, I'm 83 years old. Of course, my memory is not what it used to be. Well, that's not really true. I'm getting lost, or I can't do my checkbook anymore. Well, I'm getting old. That's just not true. As many of us know, there are people who are into very advanced years who are sharp as a tack. And the second key point is that Alzheimer's disease is overdiagnosed. And I came up with this sort of cliche that it ain't always Alzheimer's. Just because somebody has dementia, or even has cognitive dysfunction for that matter, don't jump to the conclusion that it's Alzheimer's disease. It's a common mistake in the lay public. It's also a common mistake in the medical community. And I just want to mention, I'm going to show you the different causes of dementia in just a moment, but the actual underlying disease, Alzheimer's or one of the others, that is causing this person's dementia cannot be confidently determined in life. All I can do as a well-informed, well-meaning physician in this day and age, in 2021, the best I can do is a good educated guess. The only way we know for sure what disease is causing this person's dementia is to do at autopsy, do a very detailed neuropathologic autopsy of the brain. And those are not usually done. Next slide, please. So what are the common causes of dementia in seniors? Now, in adults of all ages, there are many, many causes of dementia. But once you get above age 65, it really narrows down to this small group. And the group you see here constitutes at least 90%, probably 95% of the causes of dementia in older adults. And we're going to look at these. So Alzheimer's disease, there's vascular dementia, there's what's called mixed dementia, which in my opinion is the most common cause that I see, where I can't really tease out if it's one or two. It looks like there's two or more causes. We're going to look at a disease called Lewy body dementia and frontotemporal dementia. And I'm not going to look in detail at Parkinson's disease or alcoholism. I just want to say a few words here. Parkinson's disease, as many of you know, is a movement disorder. Stiffness, leaning forward, falls, trouble talking. It's a progressive disease, and it's a primary movement disorder. But at least half of patients over the course of the years they have this disease will develop a form of dementia. Alcoholic dementia is another subject, and I spent a good part of my early career working in a VA hospital where we saw a lot of alcoholism. There's a dispute in the medical literature as to whether alcoholic dementia is in fact a real phenomenon. I certainly believe it is. And to say somebody has alcoholic dementia, they really have had to have a daily drinking habit for 10 years or more. And it may be that they quit, but their dementia develops sometime after they quit. So I want to just focus on the other diseases in this group. Next slide, please. Alzheimer's disease is really the prototype disease. It's got its own association. It gets a lot of federal funding for research and for treatment. It's the disease most people know about or have heard about. It is characterized by a gradual onset of cognitive dysfunction after the age of 65. If somebody has an onset of cognitive dysfunction before the age of 65, it's very unlikely to be Alzheimer's disease. So there is so-called early onset, which tends to be familial. It's rare. So think of Alzheimer's disease as the onset of symptoms after age 65. They may not really have functional problems until they've had their disease for several years. But when you query the family and go back, they'll start remembering that problem started a few years ago. The second feature of Alzheimer's disease is that almost all, but not all, patients with Alzheimer's have a significant problem with short-term memory function and with executive function. So that relates to their decision-making capacity. When you do a brain scan, a CT or MRI brain scan, you find nothing. That is, the brain is normal for age. Excuse me. And the course of the disease, Alzheimer's disease is a progressive disease. People will get worse over time. They do not stabilize, even if they're taking one or more of the drugs that are on the market now that are hopefully will improve their function or stabilize them. They really don't have that effect. So somebody whose course has been stable for some time is very unlikely to have Alzheimer's disease. Next slide, please. The second disease on that list was vascular dementia. And vascular dementia, well, let me step back. Alzheimer's disease is a disease of the brain. It's the neurons, the nerve cells that make up the brain where the disease occurs. In contrast, vascular dementia is not a disease of the brain. It's a disease of the blood vessels that feed the brain. So those blood vessels become stiff and hardened and blocked with cholesterol plaque, totally analogous to a heart attack. A heart attack is not a disease of the heart muscle. It's a disease of the blood vessels that feed the heart muscle. So heart attack and stroke are similar because when those blood vessels narrow down, the blood flow decreases. And if they completely shut off, then the heart muscle or the brain tissue that was being fed by that blood vessel then dies. So vascular dementia is going to occur more likely in patients who have a known cardiovascular disease, such as a history of heart attack, or have high atherosclerotic risk. And that would mean long-standing diabetes, cigarette smoking, high cholesterol, high blood pressure, and a strong family history. So vascular dementia is an atherosclerotic disease. It usually occurs with other atherosclerotic diseases. Therefore, the onset could be at any age. It can occur in the 30s, 40s, 50s, or in an advanced age. And in contrast to Alzheimer's, which has a gradual onset, vascular dementia can have any type of onset. Sudden, that is a stroke, a gradual onset, or a step-like process where they have a problem, they stabilize, have another problem, stabilize, and it looks like a stair step. Also, in contrast to Alzheimer's, which over time will affect all cognitive intellectual functions, vascular dementia can have what are called juxtaposed problems. That is, they may have significant deficits in certain areas, but be very clear in other areas, depending on where the atherosclerotic process is occurring in the brain. And finally, where I mentioned that Alzheimer's disease is invariably a progressive disease, vascular dementia isn't. It may deteriorate, it may stabilize, or it may even improve. So when I hear somebody say, well, she has dementia, she's going to get worse over time, I don't like that, because if her dementia is Alzheimer's, yes, that's true. But if her dementia is due to vascular disease, she actually could get better. It depends on her overall health and overall condition. Next slide, please. Lewy body dementia, some of you may have experience with this. It's not as common as Alzheimer's or vascular. It is a distinct neurologic disease, a disease of the brain, and in many ways it resembles Alzheimer's disease, the same age of onset after age 65, an invariably progressive course, and a prominent problem with executive dysfunction. So those are areas in common with Alzheimer's. Next slide, please. However, in Lewy body dementia, these patients often have what are called Parkinsonian features in the early stages. So they may have a lot of trouble with their gait, falls, stiffness. Patients with Alzheimer's can get these symptoms, but not until the late phases of their disease. So somebody who's presenting in an early to early mid phase of dementia and has prominent Parkinsonian features, that's a real red flag that this could be Lewy body dementia. Many patients with Lewy body dementia also have what's called a REM sleep disorder. Most of us, when we sleep and go into REM, or rapid eye movement sleep, when we have our dreams, we actually have a period of relative paralysis. We don't swing and run our legs if that's what we're dreaming, but some people don't do that, and they actually act out their dreams. They'll swing their arms, they'll kick their legs as if they're what they're doing in their dream. And this occurs in many patients with Lewy body dementia. It doesn't mean if you have a REM sleep disorder, you're going to develop Lewy body dementia, but it's common. And then finally, any form of dementia can be complicated by hallucinations, but in Lewy body dementia, they're very prominent and they're very vivid. Visual hallucinations, seeing things that are not there, or extremely vivid nightmares that are just frightening as hell because they're so vivid. People will scream and have night terrors as if they're young children. So these are features I'd be looking for when I'm trying to make an educated guess on what the form of dementia is. I think you can hear a thunderstorm behind me. Next slide, please. The other form I mentioned is frontotemporal dementia. Again, not as common, but it's actually not one disease, but several. It's a group of disorders where the disease of the brain, it's a neurologic disease, is localized to a particular part of the brain in the frontal lobes and in the temporal lobes, so above your eyes and above your ears. Now, this is the disease that can have an onset at any age. And when I see somebody in their 60s who's had cognitive decline for over 10 years, that is to say, it started well before age 65, I'm really thinking frontotemporal dementia. It has a progressive course that can also often be quite rapid. Next slide, please. But frontotemporal dementia is characterized by a prominent problem with language dysfunction and prominent behavior and personality changes. Some people make up their own languages. I interviewed a family some years ago where the father, the husband, was developing frontotemporal dementia, and he was talking this funny talk, and the family called it dad speak because it was a gobbledygook kind of language that he had developed, which didn't make sense. These people may have a lot of anxiety, restlessness. They may have the development of profound obsessive compulsive behavior, either an exacerbation of prior OC behavior or the new onset of obsessive compulsive behavior. Socially inappropriate or criminal behaviors after age 65, or the new onset of a major depression or mania after age 65, having never had it earlier in life. These are all features that suggest frontotemporal dementia. Next slide, please. So I'm going to quickly go through some visuals for those of you who are visual thinkers. So Alzheimer's disease is the prototype disease, and we talked about its clinical features. Next slide. Vascular dementia has more in common with Alzheimer's disease than it has different. Next slide. That's also true of frontotemporal dementia. And next slide. That's also true of Lewy body dementia. So as a clinician, it's challenging. And that's why I want to highlight to you that if somebody has a diagnosis of, for example, Lewy body dementia or Alzheimer's disease, be a bit skeptical. First, be skeptical they have dementia. It may be something else. Or be skeptical about that that's the cause of their dementia, that is that disease. It's just really hard to tell in life. The only way to know for sure is to do an autopsy of the brain. Next slide, please. Let's move on specifically to decision-making processes. Now, dementia and decision-making, two common errors. First is that because somebody has dementia, you assume they lack decision-making capacity. And that is not true. Half of people with mild to moderate dementia, that is to say significant cognitive dysfunction, have intact decision-making capacity. And let me stress again, it's the decision at hand. Okay, they can decide what they want for dinner tonight, or they may be able to decide how they want to change their will. So it's the decision at hand. It's not a universal thing. Only a court can do that. So that's one coin. The other error, which is the other side of the coin, is to look at people who are socially appropriate and they're using common niceties and to assume they have capacity to make decisions. And I call this the shell of capacity. So if, as many clinicians do because they're pressed for time and they want to do a quick and dirty mental status exam, they say, "Hello, Mr. Smith, how are you today?" "I'm fine." Anything going on?" "No, I'm good." "Any problems you want to tell me about?" "No, thank you." And then you assume that they're fine. And that's just, commonly done, and it's commonly inappropriate. Those of you who look through medical records will see the phrase A and O times 3, which is shorthand for alert and oriented times 3. And a lot of times what the clinician did is what I just did, a quick and dirty yes/no question, not really assessing that person to be alert and oriented. So as I've been in this business for many years, I've developed what I hope is a healthy skepticism about what I see in the medical records. Next slide, please. No medical diagnosis automatically assigns impaired decision-making capacity, no matter what the patient has, even if they have said to have advanced Alzheimer's disease. Don't assume that they lack capacity. So you want to be skeptical of decision-making capacity in what I'm going to call red flag situations, and I'll show you those in a moment. But anytime you have a question, particularly the attorneys or social workers in the group, and you're wondering, does this person understand what they're doing? Do they have the capacity to make this important decision. Anytime you have doubt, request a formal evaluation. Next slide, please. Those red flag situations are going to be a person who has an established mental health diagnosis. And it could be intellectual disability, formerly known as mental retardation. So this is issues they've had from birth. Now, people with a diagnosis of schizophrenia or bipolar disorder or recurrent or chronic depression, if they're well treated and they're in a very good place, they can be fine. But if their disease is not optimally treated, they may be experiencing symptoms of their underlying psychiatric disorder, and they may have impaired decision. So again, anytime you're just in doubt, request a formal evaluation. And again, because somebody has a diagnosis of dementia, that's a red flag situation both ways. It doesn't mean they lack capacity, nor does it mean they have capacity. They need to be evaluated. Next slide, please. Here's one that I've sort of laid the groundwork for you. Anybody who's at risk for having delirium, that is to say, they've had a change in their health status, their physical general health status within the last 6 months. They experienced some acute illness. They've been to the ER or were hospitalized either emergently or electively. They've had a surgical procedure, where they've had one or more new drugs added to their profile or doses changed. Because they may have a delirium, which can be impairing their capacity to make decisions, and because that delirium could be persisting for several months afterwards. So if you're encountering somebody who's got a medical problem within the last 6 months, you'd really be skeptical about their decision-making capacity unless it's very obvious to you that they're crystal clear. And when in doubt, request an evaluation. Next slide, please. Some more red flag situations, which I know many of you have experienced, is a person who refuses care even though they have an obvious need for care. Somebody with metastatic cancer who is refusing treatment, and it may be a perfectly valid choice, but the question is, do they have the capacity and the understanding to make that choice? Or on the other side of the coin, which I experienced a lot in my VA years, was somebody who obviously is at the end of their life, but they're insisting on everything done. And that may be, again, that may be a valid request on their part, but the question comes up is, do they really understand what's going on here? Are they in denial? Are they recognizing the problem and the risks and the benefits of what they're asking for? Now, if somebody has the potential for undue influence, this is a legal term. I'm not a lawyer, but I work with lawyers frequently. And this is a term that comes up a lot in contested wills, was somebody unduly influenced? As the medical evaluator, I'm going to be looking to see, is somebody vulnerable to undue influence? Vulnerability means they're very dependent on one or more people for in-home daily needs. I mean, if they're very dependent, if they need help with their meals, if they need help with bathing and toileting, just imagine the lever that aide or that caregiver has over that person. You're thirsty? Okay, well, maybe I'll get you a drink. You need to go to the toilet? Okay, we can think about that. I mean, people can really take advantage of the frail and dependent older person. Again, if you realize that you have an overbearing caregiver or family, that's a red flag for undue influence. And people of more advanced years, this is a bit of an ageism, but I'll stick it out there anyway. The older the person is, the more likely they are to have some type of physical dependency or cognitive dysfunction. So be aware of people of advanced years as having a potential for undue influence. So these are red flag situations where you want to be skeptical about their capacity to make important decisions, and when in doubt, request an evaluation. Next slide, please. All right, what is the cognitive assessment? How should it be done? Okay, now I talked a few minutes ago about Mr. Smith who had the shell of capacity. How are you feeling? Any problems? Anything you want to tell me? That's not a mental status exam. Nor is the mini mental status exam a mental status exam. That's the MMSE, and I'm going to mention it in a moment because I use it. But look, it's got the word mini in it. It's not a mental status exam. It was designed to be a quick and dirty screening test. A mental status exam focuses on an interview with the client or the patient. The interview, the dialogue that the evaluator has with the patient or the client, that's the center. That's the key. Everything depends on that. That's what really matters. Everything else is supplemental. So unless there's a good interview relative to the questions at hand, that's not a good assessment for decision-making capacity. Don't dismiss what family or caregivers tell you. If they say that the person's having problems, getting around town, or they're having intermittent incontinence, and the person says, look, doc, or whoever you're talking to, I'm fine, they're exaggerating, it's not a problem. Don't dismiss what the family says. Now, they may have secondary gain. They may not be accurate, but we have to listen to what they say. So what I do is, before I evaluate the patient, I interview somebody who knows the patient very well. Where were they born? What's their educational history? What's their work history? Tell me about their family. When did they get married? Children and grandchildren, hobbies and interests. Do they drink? Do they smoke? I want to know all of these personal questions, because then I'm going to interview the patient. Oh, Mr. Smith, tell me, where were you born? And tell me about your schooling. And do you have children or grandchildren? Now notice that those are open-ended questions. Tell me about your children. Because I'm going to ask the patient to tell me about these things. And I don't want to give the patient yes or no questions. I want them to talk. I want them to elaborate. And in the process of them talking about themselves, I'm assessing lots of things. Their comprehension of language, their use of language, their memory, their interactive ability, their social skills, their mood, their affect. All of this is evident as you're talking to somebody. So that's the cornerstone of the evaluation, and you want to use open-ended questions. Next slide, please. And it's specific to decision-making. If, for example, I'm being asked to assess a person who's about to change their estate planning documents, they're going to change their power of attorney, or they're going to change their will. Some lawyers will want to have that person evaluated at the time that they're going to execute that document, because they're worried that down the road, that change is going to be challenged. So ask questions specific to the decision at hand. If it's a medical decision, you want to ask them, first you explain, and this is a whole area that we could talk another hour about, is informed consent in medical settings. If I'm about to operate on you and I tell you this is what I'm going to do and these are the risks and benefits, and then I turn to you and say, do you understand? And you say yes. And I say, do you have any questions? And you say no. That's not informed consent. Properly done, it should say, okay, would you please repeat back to me what we are about to do, what are the possible risks, and why we're doing it. Then I can make an assessment as to whether you really understand what's going on. Next question, next slide, please. So having said that and stressed that the interview specific to the decision at hand is the key, I do use other supplemental cognitive tests. So I want to highlight to you that these are supplements to the interview. They are not a mental status exam in and of themselves. The one that's most widely known and widely used is the Folstein Mini Mental State Exam, or the MMSE. It's reasonably sensitive. That is to say, most patients who have significant dementia will have an abnormal test. But a normal test does not exclude dementia, because the MMSE just looks at 5 intellectual areas. Well, what if their problems are outside those areas? They can have significant dementia and be pretty good in those 5 areas. So it's reasonably sensitive, but it's not, nothing's 100% sensitive. Furthermore, the mini mental status exam is not specific or diagnostic of anything. It doesn't tell me that they have dementia. It doesn't tell me how bad their dementia is. The abnormal score could have many possible causes. Maybe they don't like me. They're not answering my questions. Maybe they have some secondary gain not to cooperate. Maybe they drank too much last night. Maybe they didn't sleep well. There's all kinds of reasons. So be very, very skeptical if your capacity evaluation just quotes any of these supplemental tests. And the mini mental is going to be the one you'll see most frequently. Next slide, please. The clock drawing test is another supplemental test that I find very helpful. So I give you a piece of paper and I give you a pen and I say, first, I want you to listen to me. And then I'm going to ask you to go ahead and do what I'm asking. And I'm going to ask you to draw the face of a clock showing the numbers from 1 to 12 and show that the time is 10 minutes past 11. Go ahead. And then you watch the person do just that. And if they look up and ask for a repeat or more instruction, you do not provide it. So again, similar to the interview, just watching and observing gives you a lot of information about visual spatial processing, about memory, about motivation, cooperation, focus, attention, All of these things can be gleaned by these simple supplements. And when it comes to dementia, there's always an important point in the patient's life when they are no longer safe to drive. And this clock drawing test has been validated as a reasonably sensitive screening test for safe driving. It doesn't take the place of a full driving evaluation, but it's something that can be done just to get an idea. So I like the clock drawing test because it looks specifically at executive function, planning and forethought and motivation. Next slide, please. Then a couple of other tests. I usually do them all, but at least one of these, I'll just pick up a magazine at hand and please read this paragraph, and they read it and say, very good, thank you. And they'll tell me, what did you just read? And you can see the obvious benefits there, the visual spatial processing, the ability to read, the ability to speak, the ability to remember, the ability to articulate what they remember. Or I'll give them a piece of paper and say, write a sentence, any sentence you'd like. And you're looking again at all of these different factors. And the one I really like, which you may try because it's really entertaining at times, is to do the four-legged animal test in 60 seconds. You don't look at your watch. You don't want to pressure the person and let them know they're being timed. So you have some covert way of determining 60 seconds. But you ask the person to name as many four-legged animals as you can think of. And in 60 seconds, somebody should get at least 8. My world's record is 26. So if you can get somebody who gets better than that, please let me know. These are supplemental tests. They supplement the interview. They are not a mental status or a decision-making assessment in and of themselves. Next slide, please. Okay, so I'm at the end of my presentation, and what I'd like to do now is go into a case discussion. And this is a case that's based on an actual case I saw a few years ago. Obviously, I've changed some factors to make it anonymous. But I've chosen this case for several reasons that I'll discuss as we go along. And this is Mrs. Hughes. She's 89 years old. She's a retired nurse. She's been widowed twice. She has no children, and she lives alone in a private home in a very nice part of town. She's independent in all of her activities of daily living. That's bathing, toileting, feeding, getting around. She enjoys church activities, and she enjoys what she says, spending time with my widow friends. She drives to local destinations. She does her own food shopping. She keeps her own appointments. She says she sleeps well. She doesn't have a problem with falls. She's never used tobacco or alcohol. And she has designated her younger sister, Nan, as her power of attorney. And she's also prepared her will. And Nan is her sole heir. Mrs. Hughes has no active medical problems, and she takes no medications. So she has aged healthfully. Next slide, please. 8 months ago, Mrs. Hughes got a call by a man, unsolicited. The man's name is Roger, and Roger told her, congratulations, Mrs. Hughes. You have won the lottery, and you have won a $1 million prize. And he goes, explains it all to her, and she said, we're so happy. However, we need to pay the taxes due before you can receive your winnings. And I know about 3/4 of you sitting at this conference today have seen cases very similar to this. So Mrs. Hughes is speaking with Roger, and remember, this has been going on 8 months. They talk several times a day. At the same time, she also began to get visits at her door from people she didn't know who were asking for money. And she gave them money, often several $100s at a time. And over the past 8 months, she sent Roger and these door visitors over $150,000 in cash, which is about 10% of her net worth. No surprise, she's not yet received any winnings, but she continues to get requests for cash from Roger, which she promptly sends. Next slide, please. Now, her sister, Nan, has become aware of all this, and she's insisted that she stop, but Mrs. Hughes has not stopped. Mrs. Hughes acknowledges she's being scammed, but she continues to expect to receive her prize. She told her sister, Nan, Roger said I'd get my prize, and I believe him. So Nan contacted a local attorney who petitioned the court to have a conservator appointed, and that hearing is pending. At the attorney's request, the court issued an injunction placing Nan in control of Mrs. Hughes' financial assets, and that injunction will expire in 15 days. I interviewed Mrs. Hughes. I was contacted by the attorney who needed a medical evaluation. Now, you may know that all guardianship, conservatorship evaluations require a medical evaluation. either by a medical doctor or by a clinical psychologist or a mental health professional. So I was asked to do this, and I came in and I interviewed Mrs. Hughes, lovely lady, very nice neighborhood of town, very nice house, although it was a bit cluttered with 1960s furniture. And she, as soon as we sat down after introduction, she started off and she said, "I've been scammed. I've lost $150,000, right off the top." She spoke in a calm, deliberate manner. She was not agitated or in distress. She appeared younger than her 89 years. She moved around the house in a sprightly manner. She appeared clean and well-groomed. She was nicely dressed, and she was pleasantly interactive throughout the evaluation. Her voice was clear, her vocabulary and usage were appropriate. I just want to show you, as I'm going through this case, what I'm observing and what I'm going to report in my evaluation report. I'm noticing all of these things about her. It's not just a mini mental status exam. I'm looking at the whole environment. Next slide, please. Mrs. Hughes was well-oriented to person and place, but she was only partially oriented to time. She wasn't quite sure the day of the month or the year. Now, that you have to give a little slack on, because people who do pretty much the same thing day in and day out often lose track of the time. And so that's not normal, but it's not anything I'm going to hang my hat on. Registration and short-term recall were intact, and she accurately recalled 7 of 8 unrelated items at 5 minutes and 6 of the 8 of the same items 10 minutes after that. And that's how I assess short-term memory. I tell them something about me, so I'm going to remember it. And then I ask them to remember it. And then I go on and talk about something else. And then about 5 minutes later, I ask them to repeat back those things I asked them to remember. And about 10 minutes after that, I ask them to repeat it back again. And she did well. Her long-term recall appeared intact, and she recalled many details from her nursing career and her 2 marriages. Next slide. She correctly spelled her last name forwards and backwards. I like that. I like to do that. I like to ask people to do that. It's usually a visual thing. You actually visualize the word and you spell it forward and backward. She accurately made change from $1 in her head, and she correctly identified who was buried in Grant's tomb. Do you know who was buried in Grant's tomb? Most people will say Grant. And then I'll ask them the next question, who was Grant? And not everybody knows that. But if they do remember that Grant was a Civil War general, and I'll ask them, well, what did he do after the Civil War? And some people will remember that he was a president. And then if they're really good, I'll ask them, well, where is Grant's tomb? And you wouldn't believe how many people in Virginia tell me that Grant's tomb is in Richmond. And I say, I don't think so. Grant's tomb is in New York City. So Mrs. Hughes did well. She correctly named the current US president. She accurately copied 2 intersecting polygons, and that's visual spatial. And she completed the clock drawing test without difficulty. So I think you're getting the picture that this is an 89-year-old physically and cognitively sharp lady. She scored 29 out of an optimal 30 on the mini mental status test, and a normal score for her age and educational level would be 26 or better. Her thought processes were clear and linear, and there was no suggestion of anxiety or depression. Next slide, please. Now, we got to the business at hand. After I realized that I was dealing with what appeared to be a cognitively clear lady, we started talking about the scam. And she spoke openly about her relationship with Roger. She even said someone was supposed to come today while I was there and give her the cash prize. I've heard that several times. But then she laughed and she said, they've said that before, but they never come. They come up with some excuse. And I've heard that several times. I asked Mrs. Hughes, how did these people learn your address? And she said, well, I gave it to them. How else could they send me my money? So I got a little insight here as to why all these strangers are showing up at her door asking for cash. And then after a little bit of hesitation, she did admit to me that Roger sometimes calls as many as 50 times a day. She said, this scam is a nightmare, and I wish they would just give me my prize and it would end. So we talked about things she could do now to implement, or things she could implement now to limit her vulnerability. But I was concerned not only about her financial vulnerability, but her physical vulnerability. She's a little old lady living alone in a house, and there's strangers coming to her door, and she opens the door and gives them money. So I suggested, well, maybe she could change her phone number, or maybe she could give her sister Nan permanent control over her finances. She listened to me, and she acknowledged what I was saying, but she said she didn't want to do it. Next slide. So I'm going to ask you, does Mrs. Hughes have intact decision-making capacity? Now remember, the question here is capacity to manage her financial affairs. The petition was for a conservator, not a guardian. And if I'm correct, Virginia is the only or one of very few states that separates those two functions. Most states put those guardian conservator functions in the hands of one person. But this petition was just for a conservator. So do you think, and answer in your own mind, does Mrs. Hughes have intact capacity to continue to manage her money? If you think she does not, I'd like you to explain to yourself why not. And should the court appoint a conservator? And I just want to pause a moment and just let you think that through. Okay, let's go to the next slide. So when I first sat back and thought about this case, I was thinking that Mrs. Hughes was clean as a whistle and that I couldn't say she had impaired capacity. But the attorney who hired me asked me to rethink it, and I did. And I like to rethink it. And it's my practice to always sleep at least 1 or 2 nights on these decisions. I never want to jump to them. And oftentimes insights will come during the night in a dream or in a sleep. So there's this, first I want to define what a delusion is. And I mentioned it earlier when we talked about delirium. Delusion, well, first, a hallucination is when you sense something that isn't there. You see it, you hear it, you smell it, you feel it, but there is no physical phenomenon that's causing that. It's completely inside your head. A delusion is different. A delusion is a thought. It's a belief or an altered reality that is persistent. It stays there, and it's held despite clear evidence to the contrary or universal agreement to the contrary. That's what a delusion is. It's a fixed false belief in the face of overwhelming evidence that it ain't true. Next slide, please. There is a bona fide psychiatric condition called delusional disorder. There is some debate in the psychiatric community as to whether this is a real phenomenon or not, but it is out there. It's in the DSM-5. It does have its own DRG code. And delusional disorder is defined as the existence of one or more delusions lasting for at least a month, and that apart from the delusion, functioning is not obviously impaired and behavior is not noticeably strange. There's no other evidence of a psychiatric illness, an active medical problem, or a substance abuse disorder. So it appears that the person is normal in every other way except for this delusion. Next slide, please. So as I go back to Mrs. Hughes, I want to go back to that slide where I showed you that she said this scam is a nightmare, and I wish they would just give me my prize and it would end. And I offered her ways that she could limit her vulnerability, and she listened and acknowledged them, but she decided not to do it. And I decided, and I'll see if you agree with me or not, but I decided that her responses sounded irrational and that she had no appreciation of her financial or personal vulnerability. In other words, I did not think she had the capacity to make rational decisions regarding her money. And that was my opinion. And the attorney took it back to court, and Nan was appointed as her conservator. Next slide, please. That's the end of my prepared discussion. I wanted to leave ample time to go into questions and answers, and I'm going to start addressing some of the questions that have popped up, and I would encourage the rest of you, if you have other questions, please go ahead and enter them. The question from Ms. Weeks is, what do I recommend that APS workers ask clients who present with cognitive impairment? Is there a certain professional that I would recommend to get to assess our elderly? I think that when you're facing somebody who you are wondering about their cognitive performance, it's not hard to learn how to do some of these simple things. Remember, the key is the interview. Just talk to them. And, you know, we're all trained, licensed professionals. We know how to talk to people, and we know how to listen. And what are your instincts telling you? Is there something wrong here? If you think there is, then go ahead. And the second part of the question is which professionals? And that's a tough one. The person who's best suited to do this assessment is someone who knows the patient well. If they have a counselor If they have a primary care provider who is willing and competent in doing this, that's the best person, but that's not common. So I often get asked because the primary care provider does not want to do it or is not interested. So it's not easy. There aren't that many people like me out there. I enjoy doing it. I do charge a fee for it, and it's a private fee. It's not covered by third-party payers or Medicare. So it's not applicable to everybody. So Ms. Weeks, I hope I addressed your question. It's not a full answer, but Joan Thompson is a neuropsych eval the best route to determine if a patient is exhibiting delirium, depression, or dementia? Can a geriatric physician make a diagnosis of delirium? Any physician can and should be able to make a diagnosis of delirium. You don't have to be a specialist in geriatrics. Delirium is very, very common. It occurs across the entire age spectrum, but it's much more common in very young children and in older individuals. A neuropsych evaluation is, let me digress and discuss that. So what I explained to you is what I do. I'm an internist who's trained and certified in geriatric medicine. I'm not a psychiatrist, and I'm not a psychologist, but I feel very comfortable doing my evaluations. I've been doing them for many years. I know how to do them, and I take it very seriously. I don't determine somebody to be free of to lack decision-making capacity lightly. A neuropsych evaluation is a very detailed, very lengthy, very in-depth assessment, usually performed or best performed by a PhD level psychologist who's trained in neuropsychology. It usually takes anywhere from half a day to a day and a half, and it's a variety of different tests, each test aimed at specific intellectual areas. And then the tests are performed, and then the psychologist puts it all together, scores it, and gives an overall assessment. So it's extraordinarily detailed and comprehensive. They are very, very useful when you're in a gray area. So Mrs. Hughes, the case I just discussed with you, is somebody who I could have recommended a neuropsych evaluation to do a much more detailed look at her. It's not something that's usually needed, but anytime you're in a gray area or you're having trouble sorting things out, a neuropsych evaluation is a good idea, but you really have to pick who does it. It has to be a psychologist trained in neuropsychology. Ms. Weeks wanted to rephrase certain types of professional or testing to ask for when getting the testing done. What you want to ask for is an assessment of decision-making capacity for the decision at hand. In other words, Mrs. Hughes is facing a petition of conservatorship to take away her control of her finances. Does she have capacity to manage her own finances? That's the question you want to ask. Jolene Dufek asks, do you account for trauma responses to the manipulation by scammers? I'm going to have to ask for some more on that. I'm getting a note that says Sarah Morton is going to answer this question live. Is that note for me? I'm not sure.
No, sorry about that. I'm marking it that you're currently
okay.
Live.
Jolene, if you could maybe give me a little more information, I'll go on to the next question, but I'm not sure what you mean by trauma responses to the manipulation by scammers. Maybe if you help me better understand your question. Chantel Smith asks, how does undue influence factor into your decision regarding a person's ability to make decisions? I argue that a person can make decisions outside of the undue influence, so has capacity, but has a serious problem. This, I think, is more of a legal question. I'm involved, as I mentioned, in a lot of contested will cases as a medical expert, and I've been educated by attorneys that in Virginia, undue influence means the person has completely lost their free will to make a decision. It's a high bar. What I can do as a physician is I can say they are highly vulnerable to undue influence, and that may help the attorney make his or her case. But they have to be shown to be, they have no free will. They can't make a decision outside of the person who is influencing them. Somebody asked, how do you proceed in terms of helping and stopping the scamming with someone who seems to have delirium? I would make sure that person is going to get evaluated by their primary care physician. I would suggest it. I might even make a phone call to that physician saying, I've seen your patient for this particular reason, and I have strong reason to believe there's delirium due to such and such, but they're going to need a thorough medical evaluation. And they may lack capacity to decide now, but as the delirium clears, they may regain capacity. Susie Quillen asks, have you written many provisional conclusions? That is, they can manage some decisions, but not others. I have written some, but not many. There is an area in the law that allows for limited guardianship or limited conservatorship. So I try to get the attorneys who hire me, oftentimes they're the GAL involved in the guardianship conservatorship petition. I ask them to be specific. What is it you're asking me to assess? What decisions are you asking me to assess? So I try to give a very specific answer. And then that might turn out to be provisional. Yes, they can do this, but they can't do that. I've also been in situations where I say that somebody does not have the capacity to make the decisions by themselves, but should be involved with whoever the guardian or conservator is. And I mean, maybe I'm going a little far. I'm sort of telling the judge what to do, but I've not been called on that. So apparently the courts accept that. Jolene Dufek is back. We see people believe the scammer will pay often, similar to the belief that abusive spouses will change. And it's not a lack of capacity, but rather the learned response after being conditioned to trust their abuser. Thank you. Yes, okay, I see the point now. That's a fine line. I see your point, and I see both sides of that argument. I don't recall that I've really been challenged by that type of process. Somebody like Mrs. Hughes, who acknowledges she's being scammed, who acknowledges she's probably never going to see her prize, but keeps giving the money, there's a serious lack of judgment there. The challenge I have, and this is a challenge I face in every case, an attorney friend of mine once explained it to me this way, that the law has the authority, the state has the authority to step in and take away some of your rights if your decision-making capacity or your judgment is impaired because of a medical process. But the state has no authority to step in and do anything if you're a damn fool. So my role is, what's the medical process? And that's why I fell back on that diagnosis called a delusional disorder. She was delusional, in my opinion, that this prize, even though she said, I'm not going to get it, she still held to it. And it wasn't rational. So I hope that helps, Jolene. It's sometimes challenging. I'm very careful, as I've said, about stating that somebody lacks capacity, but I'm also cognizant of how they're harming themselves and how they may need their resources as they get older. But I don't try to do their thinking or their judgment for them. What to do if they refuse to get the evaluation? Is the assumption of delirium enough to get a court order for an evaluation? You cannot make an assumption of delirium. It's a medical diagnosis. I've been involved with a fair number of cases where the client is refusing the evaluation. And I usually work with the family or with the GAL. My phrase is, if you can get me in the door, I can get the job done. And I've never failed in that. I'll be a little bragging here, because once I can get in the door and sit down and start a conversation, people tend to lighten up and participate. A lot of it is fear. The court can order an evaluation, in which case I have that kind of authority behind me. But if they're unwilling to talk to me, I can't make them talk. I've never actually had that challenge. I've been involved where there was a court-ordered evaluation, but usually the family and or the GAL can get me in the door. So you cannot assume delirium. That's a medical diagnosis. Do you have evaluations that Adult Protective Services could send to primary care providers for capacity assessment? No, because the capacity assessment, the cornerstone of it is the interview. There is no form that can be filled out. Now, the state has a 3-page form, which some courts require. I sometimes fill that out, but I usually, my report is usually a 2 or 3-page narrative that answers all the questions. But the form is just black and white questions. It doesn't really, what is the diagnosis? Does this person have the capacity? And that is sufficient for the court. So you can get that, and perhaps someone on one of the panel here can direct you to where you can get those. They're available at every courthouse. Jamie Spencer asks, is there a good way to determine if the capacity issues are coming from symptoms of medication, filthy environment, or medical issues like a urinary tract infection? I've had cases where people regain capacity once they are taken off from hoarding issues or are medically treated. Is it assumed that a person's medical issues and environment are going to impair their capacity? It's not assumed that their conditions or environment will impair their capacity, but I've been involved in many cases where I felt that they lacked capacity due to an undiagnosed and untreated medical condition or an adverse environment. So I will say, given the findings I have now, this person lacks capacity to make the decision at hand. However, I strongly recommend a thorough medical evaluation of whatever I think is going on, or a psychosocial evaluation to evaluate the environment, or an APS evaluation. And I recommend that this person's capacity be reassessed in 6 months. I've done that a fair number of times, and I've seen courts do exactly that. They will order a reevaluation in a certain time frame. Beth Lee asks, have your findings been contested, and what was that like? No. Beth, I am batting 1,000. And again, I'll brag on that. I've been doing this since 2006 when I retired from my VA career. And in every case where I've done a capacity evaluation, the court has agreed with my assessment. It's been my observation that the judges are extremely reluctant to do anything that's contrary to what a good medical evaluator has said. Somebody asks, you briefly spoke about alcohol-related dementia. If there's time, I'd be interested to hear more generally. It's out there. It can occur at any age. As I said earlier, I'm looking for daily drinking for a period of 10 years or more. Now, daily drinking doesn't mean you're getting drunk every night. In fact, the current definition of excessive drinking in people over the age of 60 is drinking every night, one drink a night. If you have a glass of wine regularly every night, or you have 2 or 3 glasses of wine 2 or 3 nights a week, or beer, or a lesser amount of spirits, that's excessive drinking. So that may be sufficient to cause alcoholic dementia. The cause, why people who drink to that degree develop a dementia is not known. There's 2 leading theories. One is that the alcohol consumption, which is a regular intake, is directly toxic to the brain, and that's certainly possible. But another concept, which I think is important to many of us, particularly in the pandemic, when a lot of us are spending time alone and drinking more than we used to, when you drink regularly, you are not absorbing a lot of the nutrients in your diet. The alcohol actually blocks vitamins, minerals, metals, iron, magnesium, zinc, vitamins B12, vitamins A and D, and many other dietary constituents are not absorbed. You can be eating the world's healthiest diet, but if you're drinking to that level I just mentioned, even just a glass of wine with every dinner, you're not absorbing all of those nutrients. So the second theory is that chronic drinking exposes you to micronutrient deficiency, which in turn causes the brain damage. So I follow the rule laid out by Oscar Wilde, and that is everything in moderation, including moderation. Any other questions out there? Nicole, did I miss any questions?
No, you have not. You have answered all of the questions that were.
I've tried to answer. I hope they were satisfactory. On the slide now is my contact information. If there's another question that comes up after this seminar, I would be happy to entertain it. There's my email address down there, and there's my website if you want to learn more about who I am and what I do. It's been a pleasure speaking to my computer today and talking to you, and hopefully one day in the future we'll be able to have an in-person discussion as well.